Becky, I mean, how do you guys do it? I mean, do you see all the consults then? And how do you determine who's going to have what implant? How do you determine who's going to have either LASIK or Smile or ICL? How do you make those determinations with the two of you?
Yeah, so it's the beauty of having an OD run clinic is even when your surgeon's in the OR, the clinic is still active. So I see 100% of the consults that come in, counsel them on options, leave them with a strong recommendation of what I think is going to give them the best results of what they're looking for. Ultimately, trying to match the patient with the best technology, with realistic expectations. I mean, that's the end game of everything that we do. Try to set realistic expectations, but what that does, it gives the surgeon a lot more autonomy. They can be almost anywhere during the day. And most of the time where they want to be is in the OR. So I'll counsel the patient. If there's something unique or something I have a question on, I can always reach out to my surgeon. He's a text message, phone call away. We take a lot of pictures, send them back and forth for different things that we're curious on. So leaning on technology and those virtual opportunities where we can interact has been really key for us.
Yeah, the beauty of technology in the 21st century. That's great. So Anu, let's bring you in here. I mean, your practice, you work with several surgeons and you're like a tertiary care center. How do you determine, let's say a patient comes in and they want the best of the best. You've got world-class surgeons next to you. They want, ICOM to do this procedure. How do you determine who's not a good candidate for something?
Yeah, so I think Becky hit the nail on the head. It's realistic expectations. Technology is fantastic, but biology still has to come into play. There are limitations, whether that's the patient who has, some pathology, some kind of guarded prognosis for whatever kind of a reason, and then going with that.
Considering our premium lenses that we have, so they're all, the new ones especially are fantastic. Our Odyssey, our Envy, our Vivides. Nothing is free in optics, right? There's no such thing as a free lunch. There will always be some compromise. How do you handle, so Bobby, let's start with you. How do you handle those conversations with the expectation issue?
I try to just break it down and just say, historically we've had let's cataract surgery, we've had a monofocal lens and I'll group toric monofocal there. And then we had more of these like multifocals or bifocals where you get distance and up close. And now you get, okay, extended depth of focus has come out. Then you have there's this even middle category between monofocal and extended depth of focus, which I like to call enhanced monofocal. And really, as a patient, now it's like, okay, I could pick from a monofocal, an enhanced monofocal, an extended depth of focus lens, or a trifocal lens. Oh my goodness. How do
Oh,
you,
and LAL too. Yeah.
right. And now, I would put that in one of these categories, but, the question is which one of these categories it goes in. But I think it really becomes interesting. I just try to simplify it and say, look, there's lenses that correct one vision zone. There's lenses that correct two vision zones, distance, intermediate. And then there are lenses that correct distance, intermediate, and up close. And that would be the trifocal. But I think the biggest thing is just it's how do you handle those difficult patients? So let's take, for example, an emmetrope patient, and let's take somebody who's like a -4 myope. One thing I just try to tell them is like, okay, let's just set the foundation of where you are. So let's take, for example, -4 myope. Mrs. Jones, you're a -4 myope, so you have the world's most perfect near vision, which means, one of the things that's really important for us is as we go into cataract surgery, you'll hear people, yeah, I got a lens that corrected my far vision. And they're like, yeah, that's what I want. I have good near vision. I just want far vision. And so I try to tell them like, no, Ms. Jones, if we correct your distance vision, I would be very scared to see you after surgery. And the reason for that is if we correct your distance vision, your near vision would be, and I kind of pause and I say, well, actually, just one second. Without your glasses, how is your distance vision? And then they use a word, right? Like probably the last patient I saw was like crap. And I'm like, okay, what's really interesting, if we correct your distance vision, your near vision would then be, and I use the same word, whatever word they use, I use crap. And they're like, and it's like, all right, here we go. That's been my best way of just, because before I tell people, oh, you can't see up close, and they wouldn't believe me. But like, here we go. Now we start to see them. Okay, so great, Mrs. Jones. So if we use something, for example, like, a trifocal lens, which corrects your distance, intermediate, and up close vision, your near vision, let's say you have 100%, your near vision would go to, and then I just make up a number, like 79% of your near vision. And they're like, oh, and you get to see like if people are like, oh yeah, that's fine. Can I wear glasses on top? Yeah, sure, great, awesome. You get a chance to kind of see who these patients are. Like me, I'm like, with my vision, I'm like totally cool. Like, you know what? Even if I had dry eye and macular degeneration a little bit, and I'm 20/30 at distance, intermediate, up close, great. I'm cool with that. I could probably golf. I'm not good, but I could at least, see where I'm driving. I don't hit the ball that far anyways, but everybody's different, right? You have other people who are like, I need to be able to see craters on the moon. All right, you're going light adjustable lens, no doubt about that. That's what we're doing. So I think that being able to give analogies and even using words that are it's helpful for the like the patient's own words in describing how the vision is going to be, that's been really helpful for me in just trying to get an idea of, again, simplifying the options, kind of seeing which one they're interested in, and then really diving into like, this is how you're going to see afterwards. Is everybody going to be okay with that? Let's talk through the limitations of each of these options, whether that's light adjustable lens, whether that's, I'm going to call them trifocal like lenses now, now that we have Odyssey and Envy, versus just Panoptics, it creates more options for these patients.
Yeah, comment on that. We just got a comment on here that somebody said that they're really hesitant to recommend multifocal lenses because the results are variable. Patients ages, their cornea changes, becomes dry AMD changes, and they start to go downhill. Bobby, how would you address that with the current generation of multifocal or EDOF lenses?
I think it just at the end of the day, it's dependent on the patient. So like, okay, let's take a patient who, okay, so what, we're going to put in a lens that only corrects the distance vision, which is totally fine. But then that patient's going to have to wear a progressive. Like my dad fell off of a ladder wearing a progressive. And so for him, like, hurt his shoulder pretty bad. That's why he decided to do trifocal. And he's like a retired police officer. And we didn't let him get surgery in the beginning because he wanted to see craters on the moon. He had too high of expectations, right? So it was like, no, you can't have surgery. So I think it's all about setting the right expectation. And sometimes the answer is no, and that's okay, right? Until they get the right expectations, then they're allowed to come back and see us. And so I think that, ultimately, yes, there are changes that happen over time. Hey, but check out, also, by the way, in October, when was it? October or November, now FDA approved is a light therapy for macular degeneration. And I think in Canada, you guys have had this longer and some different versions. But I think that's going to be really great for us. Like as optometrists, potentially having some light treatment to help in these macular degeneration patients. I think that's really encouraging. So I think overall, going back to the question, like it's possible. And really, at the end of the day, it's all about expectations, right? What is it? Happiness equals results minus expectations. Like we know the results that we're going to get from these patients. Like you look at the DFU, you look at the FDA clinical data, you look at the clinical trials that's coming out. So now it's really just like how well can you set expectations for now and also for the future.